All right. Hello, everyone. Welcome to Virtual Grand Rounds. My name is Rachel Bockel, and I'm a second-year medical student at Geisinger Commonwealth School of Medicine in Pennsylvania, and this year's American Academy of Developmental Medicine and Dentistry Virtual Grand Rounds Chair. For those that are new, Virtual Grand Rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD workforce across a spectrum of experience levels. After this meeting, we will be sending out a survey for feedback on how to improve these meetings. If you guys have any questions, feel free to write them in the Q&A box, and we will go over as many as we can at the end. And if we don't get to your question, we will post the answer on the website. Now I would like to pass it over to Dr. Alan Wong, our president of AADMD.
Thank you, Dr. Bockel. Welcome everyone tonight. A very, very special treat for our virtual grand rounds. We have an amazing three-case presentation with a discussion at the very end. And the uniqueness of this is we have this a very collaborative process. We have dental students, dental residents, and dental faculty all participating, but they're all cross exchange. So you're gonna have a very exciting evening tonight with a lot of information put into one segment. I think you're going to find it very enjoyable and very enlightening. I'm going to pass it to our chair of of this committee of the mentor-mentee dental team, Dr. Jeanette LaBelle. Dr. LaBelle.
Thank you, Dr. Wong. Welcome, everyone. We appreciate you taking the time to be here with us today. This is the first of hopefully many opportunities for dental students, residents, and faculty to present in these opportunities. So without further ado, I would like to introduce our student and resident group that's going to be speaking to you tonight about cerebral palsy. Julia?
Hello, everyone. I'm going to share my screen. And is that everyone can see that?
Yes.
All right. So hello, everyone. Thank you all for joining us this evening. My name is Julia Jagannath, and I'm a third-year dental student at Penn Dental Medicine, and I will be presenting with Dr. Beers, a resident of the University of Pacific Dental School, along with Dr. Hidari, a chief resident of the University of Pacific Dental School. So I'd like to start off this presentation by first defining what is a developmental disability. According to the CDC, it is a group of conditions caused by an impairment during the developmental period that affects physical areas, learning, language, and behavior. The severity of the condition is often influenced by the impact on activities of daily living, also referred to as ADLs. ADLs, a term coined by Sidney Katz in 1950, consists of activities such as bathing, eating, and dressing. So for our presentation, we will be talking about cerebral palsy, often referred to as CP. Cerebral meaning brain and palsy meaning weakness. This is a lifelong condition, and as you can see here, occurs in 2 to 3 individuals per 1,000 live birth. It often affects a patient's ability to move or maintain balance and posture. This definition remains extremely broad and has undergone many variations to try and encompass the vast clinical manifestation of this condition. So here we see a breakdown of the categorization of CP based on the specific areas of the brain affected, the limbs affected, and the different categories of the movement disorders. The first movement disorder of CP I'll discuss today is called spastic. So 80% of patients with CP present with spastic movement disorders. This is due to damage to the upper motor neuron that affects the pyramidal tract responsible for an individual's voluntary movements. So this often presents with increased muscle tone, stiff muscles, or hyperreflexia. So spastic CP is then further categorized into 4 subgroups based on the affected limb. So monoplegia, meaning paralysis of one limb, diplegia, meaning paralysis of 2 limbs with legs affected more than arms, hemiplegia, meaning one side of the body involved. So here we often see arms are more affected than legs. Interestingly, in the Dental Clinic of North America journal, Dr. Doherty shares that patients with hemiplegia, 60% of those patients had normal intellectual development. And the last subgroup is quadriplegia, which means paralysis of all 4 extremities and trunks are involved. The second movement disorder is dyskinetic, which is a damage to the basal ganglia and deep motor neurons. With this movement disorder, you will find involuntary movements with adductor spasm and hypotonia. Dyskinetic movements are further categorized into 2 categories. Chorea athetoid, so chorea in Latin means dance. So as you see in this picture, you're going to see random, purposeless dance-like movements. And athetoid, which is a snake-like writhing movement. The second is dystonic, contractions leading to abnormal posture. So there we go. The third movement disorder is ataxic, which is due to damage to the cerebellar neurons. Ataxic movements are characterized by those movements in poor coordination or balance issues. So you're often going to see these in activities such as walking or when someone's grabbing for something. And lastly, the fourth movement disorder is the mixed category. And as like with most things, humans don't fall into that simple textbook definition, but are usually a combination of everything. So Ms. Frey, this sort of brings us to the first poll question and the brain blast question for you all. So what is the most common type of mixed CP? So if you could share the poll, this allows the participants in the series to be able to play. So we'll give it a few seconds for you guys to multiple choice. It doesn't look like I can see how many percentage. Ms. Frey, would you just tell me when we have about 80% and I can give the answer?
Sure, we have about 70% right now. So I'm going to go ahead and share the results.
Great, perfect. So for those who guessed spastic dyskinetic, looks like we had it close. Did a little tricky one there. So spastic dyskinetic was the correct answer and you deserve a pat on the back. So you can close that and I'll go on to the next. Thank you. So moving on, about 92% of cases were traced to the perinatal period, which is defined by the period of 154 days of gestation to 7 days after birth. 80% of cases are idiopathic. And recently in the article, Why Genetics Matter on mycp.com, Michael Cruer shares that although CP was thought to have no known genetic connections, his recent studies over the past 10 years have indicated that potentially almost 1 in 4 individuals may have a genetic cause. Now with COVID, Mardi Gras may have been put on hold, but this young gentleman on the left is kind of ready to rumble. Some of the clinical features you may see are presented here. Hand and finger flexion with that curled wrist. Depending on the limbs affected, you could have ambulatory dysfunction, inability to hold the head straight, scissoring or with an inward or cross-knee gait seen on the right-hand pictures. Individuals may also have visible scoliotic or kyphotic spine, which usually presents in sort of a torqued or twisted torso. So some other clinical features that aren't described in that broad definition I sort of mentioned earlier are listed here. So pain, which is 70%, may be attributed to that constant flexion or strained muscle position. The inability to speak may be attributed to weaknesses in the muscles of the throat, mouth, and tongue. However, I did highlight a key misconception and a stigma around this condition that I definitely want to emphasize, which is most notably intellectual disabilities. According to Sadowski in the Neuropsychiatric Disease and Treatment Journal in 2020, only about 40 to 65% of individuals with CP presented with intellectual disabilities. Lower rates of intellectual disabilities are observed with individuals with ataxic and dyskinetic types of CP. So just to make sure everyone's not falling asleep on a Tuesday, we're going to go to our next poll question in Brain Blaster. So if you wouldn't mind, Ms. Frey, sharing it as well. All right, so what pattern of motor weakness presents with the highest rate of intellectual disability? And we'll do the same thing if you don't mind, Ms. Frey, just sharing when we have about 80%. I feel like we need the Jeopardy question, the background.
I know. I can sing it for you if you. I'm totally kidding.
Yeah, I don't know if I should be singing.
We're at about 52%.
We got a couple people singing on me.
Okay, I'm going to close it in about 5 seconds.
Better hurry. This is the last multiple choice question for this presentation.
Okay, we're at 70%.
Perfect. All right, so we had 53%. Great job. So spastic quadriplegia was the answer. So you can close that and I'll go on to the next one. So as a future dentist, we can't forget to discuss those dental considerations and common features we'll find. In the Journal of Dentistry for Children, Rodriguez dos Santos noted a significantly higher plaque index in children with CP. Individuals with CP have changes in the oral facial region, strong development of parofunctional habits, and difficulties maintaining oral hygiene. Often patients present with siluria, which is excess saliva, but it's important to note that they're not necessarily producing excess saliva, but more so due to their inability to swallow that normal amount of saliva. This acts as a social barrier of acceptance, and managing this kind of plays the key role in an individual's quality of life. As for the oral hygiene element, difficulties with manual dexterity and neuromuscular control may pose as barriers for maintaining personal oral hygiene, and devices or accommodations should be considered, as Dr. Beers will share later on. Individuals may often present with perioral chapping, infections, and angular cheilitis, an infection at the commissure of the lips. One should never consider unilateral partial dentures for an individual with CP, for it's a serious choking hazard. As for determining a diagnosis, this condition is primarily diagnosed clinically. MRIs have better resolution for soft tissue of the brain when surveying for intracranial abnormalities than compared to CT scans. CP is often diagnosed between 12 and 24 months of age, usually with a PCP addressing or a neurologist addressing those motor milestones in regards to posture, movement, and balance. CP is evaluated on the gross motor function classification system, which addresses the severity and treatment on a 1 to 5 scale level. Often physicians are also assessing key elements such as a brisk reflex, ankle clonus, bilateral Babinski sign, scissoring posture, which we showed earlier in some of those pictures, delayed walking, feet in an equinovarus position, and tiptoe walking. As for treatment for CP, there's no magic cure. However, multidisciplinary care and managing the condition are key. Preventions start with a good prenatal care with a mother's OBGYN. Therapies include stretches, massages, electrical stimulation, and balance exercises. Medications to address some of the spastic movements we discussed earlier as one of the movement disorders may include benzodiazepines such as Valium, baclofen, tizanidine. Drugs such as tetrabenzene and trihexafenadil can help the dystonic movements. More invasive procedures such as implantable pumps or selective dorsal rhizotomy are reserved for that gross motor function classifications of level 4 and 5, so more of the severe cases. Although there's no cure, the biggest takeaway that I can give you after these 15 slides is that it takes a team working together to care for individuals with CP. So I'm going to hand over the presentation to Dr. Beers, and I appreciate your time.
Thank you, Julia. I would like to present two cases. Next slide. I would like to present two cases from our clinic that involve two patients with very different outcomes. Patient one is a 36-year-old female. She has spastic hemiplegia that mainly affects her right side. As Julia had previously pointed out, cerebral palsy may be accompanied by other comorbidities, and this is the case with this patient. Her cerebral palsy is accompanied by moderate intellectual developmental disability, seizures, a heart murmur, depression and anxiety, and a hearing impairment. Next slide. Her spastic hemiplegia makes it difficult for her to floss, and even though she has the use of her left hand is slightly affected as well, making turning around a toothbrush more difficult for her. What many of us may not notice is that toothbrushing involves a wide range of coordinated movements. This may not be possible for a patient with cerebral palsy, and it is up to the provider to determine the extent of oral hygiene that a patient can do themselves. The first photo is of how the patient presented to our clinic. The second is after a range of deep cleanings. The patient had generalized slight periodontitis, which means that the plaque and calculus had begun causing soft tissue, and bone destruction. If the patient had not come to the clinic, this would have resulted in gums becoming more inflamed and teeth becoming loose over time. Luckily, the patient's caregiver had noticed that the patient's teeth and asked if it would be okay to have her go see a dentist, which the patient agreed to. If you look at the after photo, you can notice that the patient still has some plaque present, and notice how there is some swelling present on the patient's left side, even though she had gone through treatment. In her case, turning around the toothbrush to brush the left side was not a movement that she was able to do. For patients that are able to do some but not all movements necessary for toothbrushing, different toothbrushing aids may be helpful. Next slide. So these are a range of toothbrush modifications that can be useful for the patient. There are now toothbrushes that the patient can just close down on, and that's in the left-hand corner. There are now toothbrushes that brush a tooth on multiple sides at a time, or handles that can be added to make a toothbrush easier to hold. These modifications can also be useful for patients that have arthritis or any other disorder that makes oral hygiene difficult. So they should not just be considered for cerebral palsy patients. Next slide. All right, and next slide. So our first patient had a great outcome. Due to her caregiver's quick exam and referral, she was able to get the treatment she needed and is on her way to long-term oral health. Our second patient is a 65-year-old female with a more advanced form of cerebral palsy and more advanced comorbidities. Now, oral exams are especially important for patients with more advanced cerebral palsy because they may not be able to make the caregiver aware that there is something going on. This was the case with this patient. She is nonverbal, and the caregiving facility was not aware anything was going on until she had developed severe facial swelling. For anybody who has ever had a toothache, imagine not being able to tell or show someone that you have it. This particular patient is not compliant with an in-depth oral exam. However, a quick one can be done by either the patient's primary caregiver or the primary care physician. And basically what you're looking for is swellings and cavities that would allow for an early referral to the dentist. It doesn't seem to be showing up one of the photos, at least on my screen, but there it is. Some swellings that you can see right on the palate. And this is something that if the primary caregiver can't see, this is something you can feel with your finger. All right, for some patients with more advanced cerebral palsy, a regular dental office may not be adequate. They may not be cooperative in the dental chair and may need to be referred to the hospital for either airway management, overriding medical comorbidities, or need large amounts of dentistry done in one visit. This patient in particular ended up being referred to the hospital because she was not cooperative in the dental chair, needed airway management, and needed a large amount of dentistry done. And general anesthesia allowed her to get a complete exam and required dental treatment done in a safe and somewhat quick manner. These are her radiographs, and her dental exam and radiograph showed localized severe periodontitis, which basically means you have severe bone loss around your teeth, periapical infections, and caries. Unlike the previous patient's case, her teeth were not determined to be restorable, and she required full mouth extractions to get back to oral health. Next slide. So these are the before and after photos for the second patient, which are a stark contrast to the before and after photos of the first patient that we saw. In the case of this patient, she would have received treatment earlier if she had had a quick oral exam completed, and if it had not been for something called diagnostic overshadowing. And Dr. Hidari will give us more information about that. Hi, everyone. So I wanted to just discuss diagnostic overshadowing because patients with developmental or intellectual disabilities is very common with them. So diagnostic overshadowing can be described as a concept whereby symptoms of physical ill health are mistakenly attributed by healthcare professionals to either a mental health or behavioral problem, or as being inherent in the person's disability. These patients are often over-medicated or assumed to have an intellectual disability at a young age. This can lead to a failure to diagnose and treat appropriately, which leads to significant detrimental and general health and oral health outcomes for these vulnerable patients. Many patients with cerebral palsy or other developmental disabilities are unable to communicate verbally, as Dr. Beers was just describing in the last case. Without making a basic connection with the patient, we as clinicians may fail to apply the same diagnostic principles that we would for other patients and risk diagnostic overshadowing. Next slide. I've attached here a helpful slide of examples of potential signs of possible pain in the head and neck region that a patient may exhibit, but they're unable to communicate to those around them verbally. These include changes in behaviors or self-injurious behavior, changes in diet, changes in sleeping pattern, refusal of oral or facial hygiene, refusal to take medications, or changes in salivation or apparent soft tissue movements. We're going to discuss later on in one of the following presentations looking at doing a head and neck exam, which can definitely warrant a quick referral over to a dental professional. In some instances, there may be chronic pain, which is misinterpreted, such as they always make that noise, or it's attention-seeking behavior, or it's just the way they are. And such behaviors are often the manifestation of a patient's distress in an attempt to communicate an unmet need. This just further emphasizes the importance of taking the time and going the extra mile to try to understand certain behaviors. And this sometimes requires us to think outside the scope of our day-to-day practice to treat patients with special needs to the best of our abilities as practitioners. All right, and next slide, just some resources. Thank you guys for listening to our presentation. If you have any questions, please feel free to ask them in the Q&A.
Fantastic. And now we're going to move on to our next topic, tuberous sclerosis complex.
Hey everyone, thank you so much for joining us tonight. My name is Camille Herzog, and I'm a third-year dental student at the Harvard School of Dental Medicine. This evening, Dr. Shevchik and I, under the guidance of Dr. Wong, will be sharing about tuberous sclerosis complex, or TSC, and how the complex might manifest in a medical or oral health setting. So I will begin with a background, and then Dr. Shevchik will be presenting a case study for us. TSC can be thought of as a collection of multi-system manifestations arising predominantly from this benign tumor growth, the genetics of which I'll go into on the next page. But these benign tumors exert their deleterious effects predominantly through mass effect, which causes secondary outflow abnormalities, or also by the interruption of normal tissue function. So this complex has a variable presentation, but classically would involve the skin and brain, as well as heart, kidneys, and lungs. So relevant to the work of AADMD, about 50% of individuals who have TSC will develop a measurable intellectual disability. The severity of symptoms, though, range from mild to severe, resulting in individuals who can live independently to those who might be in a more life-threatening situation. Importantly, there are no pathognomonic findings, which can make diagnosis especially challenging and delayed at times. Some of the more common findings in this complex include epilepsy, subependymal nodules, as well as intellectual disability, as we discussed, and autism spectrum disorder. Also, tumors of the heart, cardiac rhabdomyoma, more common at a younger age and tends to resolve over time. Kidney benign tumors, oral fibromas. Women can show this tumor of the lung as well. And then our skin findings, which we will show images of in future slides. So as said previously, this is a genetic condition predominantly by which a disorder of cellular differentiation and proliferation causes benign tumor growth in multiple organ systems. So this occurs through inactivating mutations of the growth suppression proteins in the mTOR pathways, the TSC1 and TSC2 most classic. So these proteins typically function to inhibit the activation or suppress the mTOR pathway. So in TSC, these genes undergo inactivating mutation and causes the mTOR pathway to be upregulated. This in turn promotes cell growth, angiogenesis, and invasiveness, and then also inhibits autophagy and apoptosis, ultimately leading to the growth of these benign tumors. And so signs and symptoms take years to develop and can often be subtle and nonspecific, leading to TSC being unrecognized or misdiagnosed for years. And so we can see in this graph the prevalence of clinical manifestations of TSC as a function of patient age. So often we find that orofacial findings may be the earliest clinically apparent sign of TSC. And a diagnosis is typically made in infancy to childhood. So in the oral cavity, almost all patients with TSC have findings. Common findings would include fibrous hypoplasia, which we can see in the upper left image, as well as enamel hypoplasia, with one study reporting that 100% of adults with TSC had enamel hypoplasia or pitting versus 7% in the general population. So most cases are sporadic, otherwise would follow autosomal dominant inheritance, and a relatively rare condition occurring equally in all races and ethnic groups, and also non-discriminatory based on gender. So if you're, starting to think about TSC in a patient, we look at a mixture of clinical observations and evaluations targeting the most commonly affected organ systems. So starting with a detailed clinical exam to look at the skin, teeth, eyes, moving on to brain evaluation, as well as this TAND checklist, which is available. And so this is kind of a checklist that's available to kind of go through common functional and clinical manifestations of brain dysfunction in TSC, which might include aggressive behaviors, ASD, intellectual disabilities, etc. Moving on to the heart, just looking for those benign tumors that appear in the various organ systems, looking at kidneys, baseline PFTs, considering a chest CT, and then genetic testing. So definitive diagnosis relies on clinical findings, genetic findings, or a combination of the two. And so definitive clinical diagnosis is made by either finding two of these major features or one of these major features and then 2+ of these minor features. It's important to realize that a genetic diagnosis is possible, but 10 to 25% of patients will have no mutation identifiable. And so these are some images of what you might find. So this in panel A, chest CT, showing that LAM with a characteristic diffuse cystic lung disease, moving over to the kidneys and an abdominal CT, renal angiogram, head CT, showing those subependymal nodules, which usually have high uptake of calcium, so they're easy to visualize on scans. And then we see these clinical manifestations starting with the hypomelanotic macule, those subungual fibromas under the nail beds, this angiofibroma, facial angiofibroma with that classic malar distribution, as well as retinal hematoma. And so morbidity and mortality is usually related to CNS, renal, or pulmonary issues. One study showed that the median age of death over their course of study was about 33 years. Of note, over the course of this study, mortality due to complications of TSC was significantly more common in patients with learning difficulties, even though the median age of patients with learning disabilities was actually lower than those without. So now I will hand it over to Dr. Shevchik to present a case study.
Great, thank you so much, Camille. So our case study refers to a patient that was referred to the University of Pacific Advanced Education in General Dentistry program. It was a 33-year-old female. Her chief concern was bleeding gums and pain on chewing. The caregiver reported that the patient had suffered a blow to the mouth 2 years earlier. The patient had not received any dental care since childhood. Through the evaluation of the patient, it was determined that they would benefit from comprehensive care under general anesthesia due to some of the patient's behavioral concerns associated with TSC. Next slide. So a review of the road to the TSC diagnosis. As Camille mentioned, it is a little challenging to come to the diagnosis at times. This patient was born after an uncomplicated 40-week gestation. Postnatal examination was unremarkable beyond a large linear nevus noted in an unrecorded location. At 6 months, the patient developed myoclonic seizures. The linear nevus, along with the seizure disorder, led to an early diagnosis of linear nevus sebaceous syndrome. At 4 years old, the patient developed facial sebaceous adenoma, which were biopsied. The patient demonstrated symptoms of autism, including echolalia and rocking tendencies. A CT scan revealed intracranial nodules common with tuberous sclerosis, and at that time, the patient's diagnosis was changed to TSC. So as you can see, over the 4 years, the patient had various evolving diagnoses, and we'll go over the importance of looking for different signs early on in this patient population. Next slide. The first findings of TSC appear as pervasive developmental disorders during childhood, so they're very difficult to provide care for. Oftentimes, as mentioned earlier, the differential diagnoses for patients in this group include linear nevus sebaceous syndrome. It's similar to TSC, but it lacks the overall organ involvement that we reviewed, as well as autism due to some of the behavioral disorders. So as you can see in the figure on the right, you can see the lipoid-like subepithelial mass the patient presented with, which was recorded during her early years. Next slide. The TSC diagnosis is based upon clinical criteria: the presence of seizures or delayed development, hypomelanomic macules, and cardiac tumor rhabdomyomas. Those were all present in this patient. Careful examination of patients of this population is incredibly important, especially when doing an intraoral and extraoral exam. Extraorally, you can examine the skin, fingernails, toenails. Intraorally, the teeth, we will see the pitting, as well on the gingiva, we'll see the fibromas. It's important for this patient, as well as others, that a CT or MRI of the brain and ultrasound of the heart, liver, kidneys are performed to identify tumors. The figure on the right shows some of the tubers that were located in this patient, particularly underneath their fingernails. Next slide. Extraoral findings, we often focus a lot on the intraoral findings in the dental community, but extraoral are just as important. As you can see, there were multiple pebble-like pink tubers on a facial mask of this patient, as well as small cornified and pale tubers on the finger and toenail bed, as indicated by the figure on the right. Next slide. So some challenges, concerns, and outcomes with TSC patients and oral care. For the preoperative workup for this patient case in particular, an electrocardiogram was performed, a comprehensive metabolic blood panel, as well as physician's clearance for anesthesia was performed. The cardiac rhabdomyomas are common finding in TSC patients, about 30 to 60%. So it's important to rule out cardiac issues prior to scheduling a surgery for dental work. Next slide. The dental implications we have already discussed, but here's a figure for this patient in particular, include enamel pitting, the high vaulted palate, which can make taking intraoral radiographs outside of the hospital dentistry settings very challenging, poor hygiene as a result of diminished mental capacity, as well as intraoral tuberous lesions. So you can see the enamel pitting, the intraoral tuberous lesions, and the high vaulted palate in the figure on the right. Digital radiographs as mentioned, are difficult to perform due to the V shape of the dental arch and the large tuberous growths on the palate. Next slide. The intraoral exam of this patient found no clinically detectable caries or cavities. There was generalized mild periodontitis secondary to the plaque and calculus buildup. Her salivary flow was consistent. They performed a periapical radiograph of tooth number 8, which we know the history of trauma in that area, and a radiolucency was found around that tooth, which is a central incisor. You can see some discoloration in the figure here on the right. During the dentistry visit at the hospital, root canal procedure was performed on the tooth number 8, enucleation of a cyst, which was about 8 millimeters in diameter, and the cyst was not intact for a biopsy. 4 tuberous specimens were removed from the palate, and those specimens were biopsied. The oral pathologist diagnosis for these specimens was fibrous hyperplasia, which is consistent with a TSC diagnosis. Next slide. As mentioned earlier, there is no cure for TSC. Symptomatic treatments include anti-epileptic drugs, medications for behavior, surgery if complications arise related to the tumors, as well as an mTOR inhibitor. Patients with TSC need to be regularly monitored for development or changes in their condition. Next slide. So future improvements for patients of this population, it's really important, as with this patient case in particular, that we identify TSC patients as early as possible to prevent long-term organ system damage. As mentioned earlier, some of the early diagnoses this patient received have no organ involvement, and it wasn't until she was 4 years old that they actually came up with a conclusive diagnosis. Even though a lot of the symptoms of TSC patients were identified early on, the full picture wasn't found until a later date. Another future development would be the development of a referral guideline through future studies, which could aid in the diagnosis of TSC, resulting in lower morbidity and enhanced quality of life for these patients. Next slide. So now comes our poll question for this presentation. So what are some of the pathognomonic signs of TSC?
And Ms. Frey, whenever you think enough people have responded, feel free to end the poll.
All right, we're at 51%. I'll go ahead and end the poll.
Thank you. So a lot of you have been paying great attention. Enamel pitting is indeed one of the pathognomonic signs intraorally we look for in the dental community for a sign of TSC.
And I think important to note that although it is a sign, a pathognomonic sign, TSC doesn't have any pathognomonic signs. So I think the key was wrong there. But it's more a conglomeration of looking at the clinical genetic picture altogether to come to a diagnosis of TSC. Great, and I think that, yep. I think that will hand it off to Dr. Wong to introduce the next group.
And I'll hand it off to Dr. Lavelle.
Excellent. All right, so thank you for presenting that, guys. That was great. To finish off our presentation, I guess our third presentation of the night will be on HPV. So I will turn that over to Annalie and Catherine.
All right, thank you. So I will share my screen now. Okay.
Awesome. Hi, everyone. Good evening. My name is Catherine, and my partner here is Annalie, and we'll be talking a bit to you all about HPV positive squamous cell carcinoma. Next slide, please. Of course, to begin, we have no conflicts of interest to declare, financial or otherwise. Okay, so to begin, we'd like to start with a poll, a little bit different. We'd like to gauge everyone's comfort levels with managing a patient with HPV. So are you not comfortable at all? Maybe you've had some level of comfort. Maybe you've seen some patients with it, and perhaps you're an expert. And Ms. Frey, again, if you wouldn't mind just closing it when you think we're good. Thank you.
All right, we're at about 57%. So I'm going to end it in about 3 seconds. So you better vote if you're going to vote.
Wonderful. Okay, thank you. Most of you, it seems like, have had some level of comfort but never seen a patient. So hopefully for those of you that are less comfortable or would like to be more comfortable, we'll be able to provide some information for you today. Next slide. All right, so starting off, a little bit of background on the HPV positive SCCs. Why is this topic important? So about 80% of people will be infected with HPV in their lifetime. And in turn, HPV causes about 70% of all oropharyngeal squamous cell carcinomas. HPV has surpassed tobacco use as the leading cause, and incidence of this among men has increased or has actually doubled in the last 20 years. And so this is not the only demographic that is at risk. Age is a factor as well, for example, and Annalie will discuss this later in the slides. Next slide, please. So what is HPV? HPV, or human papillomavirus, is of the Papillomaviridae family. It's got an overall prevalence of about 7% of our population, and its transmission can be direct contact, saliva, fomites, from mother to child, auto-inoculation, say if a child has a wart on their hand and touches their mouth. It typically incubates for 3 weeks to 2 years, and lesions may be on the skin, mucosa, or genitalia. Now, there's a variety of different forms of the lesion. The lesion can be benign. So on the top right image, you will see verrucus vulgaris. It's a non-genital benign lesion that can involve the skin. The bottom picture is a papilloma, which is a non-genital benign lesion, typically involving the mucosa. And an interesting thing to note, because this is an AADMD presentation, one benign lesion is oral florid papillomatosis, and this is actually associated with Down syndrome. We also have epithelial dysplasia, which is a pre-malignant lesion, and of course, SCCs. Next slide. Now, we know a lot about HPV in the sense that we are able to distinguish 198 or have established 198 different genotypes. And these are actually really important for us because it helps us determine the prognosis for our patients. If our patient, say, has a low risk HPV, it will typically clear faster. It won't be as persistent. And it typically comes in the form of something like warts. Not typically, but that's what we're familiar with. At the same time, if our patient has a high risk HPV genotype, this could be a lot more dangerous. It can clear slowly, be more likely to be persistent. And actually, HPV-16 is a single genotype that is responsible for the majority of HPV-associated cancers, about 90% of actually HPV-associated oropharyngeal cancers. So important for us to know, and of course, there's concurrent infection possible of oropharyngeal and genital HPV. Next slide. The head and neck oropharyngeal cancers that we're talking about are typically found in the tongue base, the tonsils, and the pharyngeal walls. HPV is typically not a driver, even though it can be found in cancers of the oral cavity. So this is tongue, buccal mucosa, gingiva, floor of mouth. And so we're focusing today on oropharyngeal cancers. Next slide. Now you can see this is what the patient presentation might look like. You can see on the top left picture, the right tonsil, when compared to the left, is enlarged. And if you were to palpate the base of the tongue, it might feel firm. The tongue is also deviated to the right side when it's protruded. And this patient was also experiencing trismus that they hadn't before. And so that's lockjaw when the patient has trouble opening their mouth. The bottom right picture is quite critical. You can see that this is a cervical lymphadenopathy. So the cancer is actually metastasized to the right neck. And this is a quite common presentation that we can see. And we'll see it again in our case on the next slide. So HPV positive SCC case. We have here a male in his 30s with the neck mass that we mentioned before, the cervical lymphadenopathy. This patient was actually brought to the hospital for a motor vehicle accident. He had multiple bony fractures, and a CT for that showed this neck mass. Now, the neck mass was excised 2 months later and actually shown to be an HPV positive, poorly differentiated SCC. At 3 months, a PET scan showed extensive base of tongue mass on the right side also. Now, there's a few important things to note about this patient. The chief complaint was that he had noticed the swelling in his neck the year before the accident, but hadn't done anything about it. This is really important for us because a thorough head and neck exam could have discovered this sooner. A patient might think that, it's just a little lump, not necessarily important to get checked out right away, but this is even more critical for our population of people or persons with disabilities because they're even less likely potentially to advocate for their own health. So it's important for us to do routine head and neck exams whenever we see our patients. Another thing to note is that this patient smokes but does not drink. However, this kind of cancer is typical actually in non-smokers or light smokers. So smoking is not necessarily a predisposition. And the last thing to note is that this patient potentially could have avoided the situation had he been vaccinated. So we'd like to recommend, and we'll talk a bit more about this later, HPV vaccine, especially given that this patient is in his late 30s. Next slide. So you can see here that these are the CT scans for the patients. On the left side, it was the intake image, and you can see the neck mass that was later excised. And we also have PET scans, not shown here, but that showed the tongue mass. Next slide. And this is the panoramic radiograph for the patient. Now, this pano was taken by the physicians who were seeking dental clearance before this patient got radiation therapy for cancer. It was not taken explicitly because of the mass. You actually cannot see in this image the lesion. And this is something that is critical to note, is that panoramic radiographs can be useful diagnostic tools, but they should not be the only one. Next slide. This is another example where you can actually see a mass in the pano. This is actually an amyloblastoma. But in this case, the pano was taken, the lesion was seen there, and then the physician was able to view it clinically. Next slide.
All right, so moving on to a comparison of the risk factors and the profile for HPV positive and HPV negative squamous cell carcinomas. Both disproportionately affect men, but the rest of the profile is different. So often patients with HPV positive SCC are younger, and the risk factor is primarily sexual partners as opposed to alcohol or tobacco use. According to Gilson's, persons with greater than 20 partners, 1 in 5 are infected with HPV, whether it's genital, oropharyngeal, or both. And oropharyngeal infection of HPV is where the risk factor for HPV positive SCC lies. And the prognosis between each is different as well, which we will discuss in a few slides. So next is the diagnosis and when to refer. If you see a suspicious lesion or you can palpate it at the base of the neck, refer to a specialist for a biopsy if you're not comfortable doing it yourself. And once a biopsy is taken, the pathologist will assess it for squamous cell carcinoma. If the lesion was found in the oropharynx, P16 immunohistochemistry testing will be ordered. And an example of P16 testing is shown below. A positive test will stain as seen on the left, and a negative test will not hold stain as seen on the right. At higher magnification, the basaloid versus carotenoid appearance of HPV positive versus HPV negative squamous cell carcinoma can also be seen. Now, however, if the P16 testing is not clinically fully able to be seen, so P16 testing is a surrogate marker and generally provides enough information. But clinically, if there's a question as to whether the patient is HPV positive or HPV negative, ISH testing will be ordered to confirm the diagnosis. And proper diagnosis is crucial to determine the prognosis and treatment. So as far as treatment and prognosis are concerned, the most common treatment for HPV positive squamous cell carcinoma is a combination radiochemotherapy, which was seen in our patient case. When analyzing multiple studies, prognosis can vary slightly due to independent factors such as staging and age of the patient. However, it's generally agreed that HPV positive SCC has a high survival advantage compared to HPV negative SCCs. And this is a cancer caused by a virus, not a mutating genome from lifetime of smoking and drinking. And that's why there's a better prognosis and a better response to therapy. The patients are also generally younger and healthier. So according to Chaturvedi, the long-term survival over 15 years after cancer diagnosis of HPV positive patients was significantly better than that for HPV negative squamous cell carcinoma patients. And looking at the Lil study, the overall 5-year survival has been specified with 83% in HPV positive versus 37% in HPV negative. So that's a pretty significant difference. Now, here's an example of a very quick extraoral and intraoral exam. So to preface, during COVID times, it's a little tough to find a socially distant open chair in clinic. So another student and I filmed this in our preclinical facility during lunch. When performing these examinations on a real patient, we would wear eye protection, gowns, and face shields. So first, you want to check for symmetry to see if you can notice any masses or anything off. You want to check the hairline and behind the ears for any suspicious lesions. And you want to check the nose piece, a common place for basal cell carcinoma. Next, you want to palpate the lymph nodes bimanually and bilaterally, the posterior auricular, preauricular, submental, sublingual, posterior cervical, anterior cervical, supraclavicular, then moving backwards toward the occipital lobes to see if you feel anything firm or non-moving or anything or any type of masses. Next, I have the patient swallow, so I can feel their thyroid, which is sometimes hard to locate in a younger patient, and I palpate either side to see if I see swelling. Looking for symmetry once again. Next, cut the video. I change my gloves because we're moving intraorally, grabbing a piece of gauze and grabbing the patient's tongue and pulling out as far as I can. I tell the patients this might be a little bit uncomfortable, but it's important to inspect the lateral borders of the tongue and the ventral borders. Then palpating the floor of the mouth with one finger and putting pressure underneath the chin so you can feel everything. Looking quickly at the rest of the mouth, and then we're done. So ideally, you would like a more thorough intraoral exam. If anyone would like to see one of those, I can provide you with information later, but that's that at first. So according to Karpin, 53% of patients, a neck mass is the presenting symptom in HPV positive SCC. So palpating lymph nodes and checking for symmetry, you can often see or feel this, which is why it's so crucial. And often patients with base of the tongue masses, you will be able to see them if you pull the tongue far enough out. So another reason that an intraoral exam is crucial for not just this disease, but multiple. Now, the good news is that HPV positive SCC can likely be prevented through the Gardasil vaccine. And right now, Gardasil is the only vaccine available in the US that has been approved. It's a 9-valent vaccine, and it is protecting against the high-risk forms of HPV likely to cause cancer, 16 and 18, as well as others. And it's important to note that it only protects against naive HPV strains, which is why it's important to vaccinate early before infection. It's best to get it in before the 15th birthday, as 3 doses are required if the child is over 15, but only 2 are if they're younger. Children can receive the vaccine as young as 9, but 11 to 12 is the most common age. And 26 is the age of insurance cutoff, and 45 is the absolute cutoff for vaccination. Now, breaching the subject of prevention with the vaccine can be awkward if it's framed as prevention of a sexual disease. And often you will be speaking to parents about their children, and most don't really want to think about that. So one way to breach this topic is to include it on a med history form and to bring up the topic that way. So are there immunizations up to date? Gardasil, COVID, Tdap. And when talking to patients, stress it as cancer prevention and leave the sex out of it. Just as you could prevent tetanus infection with a tetanus shot, you can prevent oropharyngeal cancer with the Gardasil vaccine. And that's just one way. Going back to our patient case, if he could have been vaccinated as a child, it is very likely he would not be in the situation he was today. Now, the impact of COVID-19. So decrease in childhood vaccinations. Parents are afraid to bring their children to clinics, and decrease in regular visits, which we saw in our patient case who was avoiding the doctor because of COVID. So these immunizations that we see here, the numbers are provided by Vaccines for Children program, comparing doses in 2020 to those in 2019. And the HPV vaccination is down 21%. Now more than ever, it's important to follow up with your patients and make sure that they're getting their regular checkups and children are receiving their vaccinations. And considering these impacts in vulnerable populations, such as the IDD population or geriatric population, like Catherine mentioned and others mentioned, often IDD population, they can't advocate for themselves as well, and they can't express it as well. So many IDD patients have health concerns that may be unmet due to the pandemic, but it's important they're still receiving their care during this time. And one more thing I wanted to mention, when doing an extraoral or intraoral exam on a patient with a disability, they often have sensitivity to touch. So Tell, Show, Do is a great tool to use. You can model it on their caretakers first to try to lessen the dental anxiety, because you would never want to touch the patient without their consent if they're anxious or nervous. So that is where our poll comes in. So our next poll is, how do you feel about regularly recommending the HPV vaccination to your patients? Still not comfortable, somewhat comfortable, comfortable, and comfortable, and have recommended it in the past. And Ms. Frey, you can close it whenever you see fit.
All right, we're at 53% and climbing. I'm gonna
Last
close
poll of the
it.
night, so.
I'm gonna close it in about 10 seconds, people. We really do need the Jeopardy music. I'll work on that for next time.
Yeah, I can't sing. Otherwise, you guys don't want to hear that. Otherwise, I would try.
All right, here are the results.
All right, good. So that's awesome. If anyone is still not comfortable, we can talk more about how to breach it with your patients and what to do in the future. But it's great to see that a lot of you would be comfortable recommending it and that you have recommended it in the past. So last thing, our acknowledgement. So we want to say thank you to Dr. Fristino, Dr. Dion, Dr. Crystal, Dr. Aya, and Dr. Kathleen for their help with our presentation and their constant encouragement and support along the way. We could not have done it without them. And thank you so much for your attention. And these are our sources. If anyone would like these, we can print them out for you.
All right, 3 amazing presentations. I'm encouraged. The Student Resident Committee for AADMD Dental, you make us very, very proud, and I learned so much tonight. So thank you, all the presenters, the students, the residents, and especially the mentors in the background. So I think we're going to move into the question and answers. Is that right, Rachel?
Yeah, it looks like we don't have any questions right now. But it was an amazing presentation, and thank you all for joining us, and thank you presenters for presenting today. Yeah, we don't have any questions at this time.
Okay, well, there might be a few coming up. So I just wanted to not recognize, but this month, of course, is Autism Acceptance Month, but it's also oral cancer awareness, I believe, as well. So very, very apropos topics. A reminder that our patients, we should be looking at them as a patient, not just as dental, but the overallness of the thing. So in our last presentation on HPV, thank you for reminding us that we should be looking not just at teeth, but looking beyond and making that as inclusive health as well. As we have no questions right now, I'm going to invite some of the faculty or the mentors to make comment and mention. I noticed Dr. Seth Keller, our neurologist, is here. Seth, do you want to say something regarding the presentation?
Yeah, absolutely. Thank you very much for inviting me. It's actually great to see these topics covered, and great presentations, folks. I think you did a really tremendous job. And I'm a neurologist, and I think it's very interesting to listen to much of what you're talking about and how it's relevant to me as a neurologist: seizure disorder, spinal disease. And I think it's great that, because these issues encapsulate on how much these different physical issues might also have an impact upon other medical specialties. And so one thing that we do is, when we talk about these cases, is how the management might even have an impact upon what I do as a seizure doctor. So the medications that I might use might have an impact upon oral health, and vice versa. or movement disorders. So I also treat spasticity. So I think it's really good to have these all in mind about why we in the AADMD want to really work together with our oral health colleagues, because there's such a huge overlap between oral health, medical health, behavioral health, and then of course family and social issues too. So it's a holistic approach that we all like to do. So thank you very much, and it's great to be on.
Thank you, Dr. Keller. The beauty of AADMD is we do bridge medicine and dentistry. And Seth, thank you for being our expert and looking at our presentations earlier. I wanted to thank also.
It looks like we have one question that came in. If Rachel wants to take it.
Please do.
Absolutely. So the question is, your first presentation showed a picture of a toothbrush that looked like a denture. Can you talk about its use and how we can get, where we can get one?
I think I can reshare. I think that was Dr. Beer. So let me reshare the presentation.
I believe, while you're bringing that up, I believe Colgate is the company that presents, that has that recently, if I'm not mistaken.
It's called a 360 brush, and a number of companies are selling it literally on Amazon. There's little kid versions too. So where the handle is, it looks like a little lion or a little hippopotamus. Super cute, really useful for children who are struggling. So you can just put it in their mouth and it does the vibrating kind of, but it's a good option. It's one of the newer things on the market, and Sonicare does one too. They're fairly inexpensive, and it looks like it says also known as Auto Brush by Dr. Wells.
Dr. Wong, you mind if I jump in real quick to add something in there?
Please do, Dr. Seabar.
Great, thank you. One thing about toothbrushes, and they come in all flavors and shapes and sizes, just like we do. One thing you can consider using is some silicone putty and make custom handles for your toothbrushes. For some patients, it's very useful, especially those with neuromuscular disorders, to really fit their hand. And so that's something we do at the dental school, and you can do that in your practice as well. And it's very easy to do. So thanks.
Thank you, Dr. Seabar. Again, I just want to highlight the fact that these are dental students, dental residents presenting, but they're collaborating from cross country. It's just an amazing job that you all did. I'm so very proud of you. Dr. Frustino, thank you for helping coordinate this. I know that many of the other colleagues of yours helped with this presentation. Did you want to say anything as well, since we have you here?
Thank you for inviting me. I think everyone did a great job. I learned a lot tonight, and I'm really happy that Annalie and Catherine were able to get the message out about HPV, and especially the impact the pandemic has had on all childhood vaccinations. So it's really important. I hope that you learned something and that you find comfort in talking to your patients about HPV and getting them vaccinated, because beginning at ages 9 is really where we want children to get vaccinated before their first sexual encounter. Well before their first sexual encounter, but that's the important key, is getting vaccinated before HPV is introduced into the system. Everyone did a great job. Thank you so much for having me.
Thank you, Jennifer. Again, Dr. LaBelle helps share this project. We're going to have more presentations from student residents. Upcoming ones, I think, is autism, Down syndrome, and a few others, and we'll be doing the same similar things. So tell your students and residents to contact us, and we'll put them on the committee. And I'd like to invite everyone to our upcoming conference that's coming up in June 4th to 6th. And it's a great opportunity to learn more about collaboration, innovation. We have the director of the CDC as our plenary speaker. We have NIH, we have World Health Organization, we have I think Black Caucus as well. We have other wonderful presenters and different plenaries. This is all being sort of sponsored generously by University of Pennsylvania. And I'd like to thank Dr. Mark Wolf for all his support in this process. So thank you for everyone for showing up. Dr. LaBelle, do you have any last closing words?
Hi, Alan. I do not. I think everyone did a really great job, just to echo what everyone else had said. Again, these are students and residents that are doing this, along with the mentorship of wonderful faculty and specialists. So thank you, everyone who took part in this project. It's a really great opportunity to work together, and also for our medical colleagues and other disciplines who are able to attend tonight and get the message out there, working together. It's really an interdisciplinary approach to manage our individuals with IDD. So we're really happy to have that conversation and to be a part of it. So thank you, everyone who's been involved. It was wonderful. I learned a lot as well.
Great. And again, I think Jessica, you just mentioned something about our student resident curriculum committee. Yes, we're going to integrate everyone with our national dental curriculum project as well with Dr. Frey, and we're looking forward to working with everyone. So again, congratulations to everyone, our fantastic job. So proud of you, and continue doing what you do and inspiring others. So any last words, Courtney? If not, I'm going to wish everyone well.
I'm good.
Okay.
Thank you,
great.
everybody.
Have a great night, everyone. Thank you.
Bye-bye.
Good night.
Thank you.
Bye-bye.
Thank you for this opportunity.
Of course.